My name is Louise Halfpenny and I am the Director of Communications for West Herts Hospital's NHS Trust. And I'm delighted to have Vicky Houghton with me, who is our Matron for Intensive Care, and Vicky is also the Chair of our Joint Consultative Committee, so that is the group of union representatives at the Trust. So I'm here to talk to you about Your Care, Your Views, and that is the name of our public engagement programme for the changes and the proposals which we want to explain a little bit more about tonight. Just a few ground rules for using Zoom. So we do want lots of questions from you. I can see some familiar names out there, so I'm sure we're going to get some questions. So some of you will know how we're managing this. We're doing it through the chat function. And if a couple of you have the same question, I'll put them together. So if I don't ask it in exactly the words that you've typed it, it might be because somebody else has asked the same or similar question. We will try to get through as many as we can and keep sending them. Start sending them as soon as you have the question, so that when we finish the talk, we can go straight to your questions. Please send them to West Herts Communications. So the aim of this session, I should just tell you that the session is being recorded. I'm sure you've seen the little red dot there, but it is being recorded. Now, the aim of the session is to talk over the proposals for us that we've been working on with our clinicians, like people like Vicky, our consultants, senior nurses and heads of department. And we want to talk to you about how we want to deliver services in the future. In particular tonight, we are going to look at critical care. And as I said, there will be opportunity at the end to ask questions. So a little bit of background for you. We have been working for some time, many years in fact, with Herts Valley's Clinical Commissioning Group on our plans to deliver better facilities and to transform our services. And in particular, we have been trying really hard to secure funding for major development of our 3 hospitals, Watford General, Hemel Hempstead Hospital and St Albans City Hospital. And we are closer than we have ever been, or we feel closer than we've ever been before, to having that major investment coming our way. Some of you may remember that in 2019, the Prime Minister Boris Johnson visited Watford General Hospital and he made an announcement that West Herts is one of the trusts in the health infrastructure plan, and that's called HIP1 because we're in the first wave. It's also known now as the New Hospital Programme, and instead of there being 6 trusts, there are now 8. So the language has changed a little bit, but importantly, we're still in that first wave. So in order to secure the funding, because I have to tell you, it's not just as simple as the Prime Minister standing up and telling us that money is coming our way. We have to do an awful lot of work to secure that funding and to negotiate the amount that we think is the right sum to do the work we want to do. So we are working through something called an outline business case, and we need to demonstrate to our regulators, so that's NHS England and NHS Improvement, as well as the Department of Health and the Treasury, that our proposals offer value for money and that they can be delivered by 2025 or soon after. So as I said, the name of our public engagement programme is called Your Care, Your Views. It is similar intentionally to Your Care, Your Future. That was a programme that was run some time ago between ourselves and Herts Valley's Clinical Commissioning Group. And it's similar because many of the aims are similar. So we still want to provide as much care as we can closer to home, moving services out of hospital settings if they don't need hospital facilities, and really thinking about preventative care as well. So our proposals have come partly from Your Care, Your Future. They are also influenced by national strategy, and a lot of hard work has gone on, even though our clinical staff have been on the front line dealing with the pandemic. They've also given a huge amount of time to work on our clinical strategy, our clinical brief, and the engagement documents. And so if you really want to dig into the detail a little bit more, I would say that the clinical brief is a good document to look at because it describes where services will be delivered from across our 3 hospitals. Importantly, I want to tell you, as time is ticking, that our survey closes on the 24th of March. So we're really interested in your views. We really want you to read the material, to absorb what we tell you tonight. You can also look at other meetings online. So we've been running these meetings now all of last week, this week and into early next week. So there's plenty of material to look at. And then we really want to see if you agree by understanding the responses to the survey. So I know the phrase is choose company, three's a crowd, but we actually think three's company because we think our 3 hospitals can work together brilliantly, really sort of accompany each other because they complement the services delivered on each site. And broadly, the proposal is for Watford to remain as our emergency specialist and complex care site, and for St Albans City Hospital to be the site where we deliver planned surgical care, planned cancer care, and an urgent care service. And the little asterisk there is just to indicate the fact that the minor injuries unit at St Albans City Hospital is currently closed, but in the future we hope that will reopen, but as an urgent care service. And at Hemel Hempstead Hospital, although the transformation there is more in terms of service than building, it is nevertheless a real transformation in that we want to make it a centre of excellence for urgent and planned medical care and to look after people with long-term conditions. The other mantra that we have is to consolidate and not duplicate. Over the years, we have really spread ourselves, probably too thinly, across our 3 sites. And that does mean that we don't always have the right facilities at every site, and that sometimes we are stretching our staff so they are spending more time travelling than they are actually with our patients. So we really want to group our specialist teams together and make sure that they have the right facilities to provide the best care. And in doing this, we will be able to provide more one-stop clinics. And these are clinics where many steps of your treatment are provided in one visit, which may be a diagnostic that gives a rapid result that leads into a session with a consultant or a clinical nurse specialist. And so by the time you leave one of our sites, you have a real understanding of what the next steps are, and you may even have begun some of your treatment. So rather than you coming backwards and forwards, we hope to provide one-stop clinics, and that will be a particular feature at Hemel Hempstead and at St Albans. Thank you. And underpinning all of this is huge digital transformation. Work has already started, and we are moving towards an electronic patient record, which is something that's going to really transform the way we work, and it will help us see data from other health settings. So we will be able to have a better view of patients' records when part of their treatment has been provided by another organisation. And we are also enabling patients to send their data to us remotely. So for instance, our virtual COVID hospital, which was the first in the country, has now treated around 4,000 patients. And many of those have been able to transmit vital information such as the oxygen levels in their blood through technology, and that has enabled them to recover well at home whilst we can monitor them and understand exactly how they're doing. Our virtual appointments have been broadly welcomed by our patients, and they do have benefits in that patients' families can also join on the appointments, so that can be really helpful when there may be a son or a daughter or another family member who wants to understand what's going on in the consultation. And diagnostics is also another underpinning feature of our proposals. And so we plan to make huge investment in our diagnosis and to really increase the speed with which we can get the results. So we want to particularly focus a lot of rapid diagnostics at St Albans City Hospital, where there will be MRI and CT. And at Watford, we will update our diagnostic services. And at Hemel Hempstead, we will introduce DEXA scanning, which is a bone density test. Thank you. And the current challenges, as I explained a little bit, are really to do with the 3 sites. And this is about stretching our staff across 3 sites. And that can impact on the training opportunities for staff, because they haven't always got their senior colleagues there. And it is also good to have your senior colleagues there if you need a second opinion in a hurry. And also, if we have our teams grouped together, then we are less likely to need to cancel a clinic because of unexpected staff leave. So you've heard enough from me. I am now going to hand over to Vicky. Over to you, Vicky.
Hi, good evening, everybody. The benefits of consolidating the service is obviously that our proposals will allow speciality staff to work from fewer sites. We're not spread, as Louise said on the previous slide, across the 3 sites. We'll just be focusing each teams on 2 of the 3 sites. And so then we'll obviously build a stronger team, which will provide the better facilities and a better working environment for the staff. They're not having to drive across site halfway through a day and spreading the teams around the 3 sites. This in turn will obviously boost our job satisfaction, and it will also aid our recruitment and retention, because staff, when we do interview them and discuss them, they do like to stay on 1 or 2 sites. They don't like to be pushed around sites or on day shifts just between 1 shift. Hopefully in turn this will reduce cancellations, and it will increase the presence of senior staff on each site. There'll also be some comfortable and welcoming rest areas for our hardworking staff, so staff can rest and recuperate in our new redeveloped buildings, but also staff can network with each other. At the moment, we're all very separated in our areas. It'll be really nice to work as a big team, West Herts team, and work together. And it's nice if we can have staff rooms that we can share. And the prospect of new facilities is, sorry, excuse me, I'll just hang up that because otherwise it's going to keep ringing.
This is the problem of catching people when they're at work, isn't it? Thank you. Are you okay?
Sorry,
to
yeah, no,
us?
it's fine. Yes, I'm very sorry. And then obviously I got to the last one, didn't it? The prospect of new facilities is a massive morale boost to watch it being built up in front of us for current staff, and it will help us recruit in the future, because working in a new hospital will be very nice and exciting. So at Watford General, obviously we're going to have the extended and improved emergency and specialist care services. Part of that will be an urgent care treatment centre, a larger emergency department with assessment areas. Our emergency department at the moment is struggling in lots of bits of nooks and crannies around the ground floor. It works well, but it would be great if it was bigger. We'll have a bigger and acute admission service. Obviously we can take bigger high risk surgery patients here, and then obviously the critical care, which is my speciality, will be slightly bigger as well and be fit for purpose. We'll have the fracture clinic next to the emergency department, and then that includes with the complex diagnostics again, which Louise mentioned earlier. We'll have more car parking facilities. We'll have the multi-storey car parking facilities, and we'll be able to have more multidisciplinary meeting spaces. So we'll have bigger rooms to do that, which is what we need now. We'll have the new specialist services such as inpatient neurology and inpatient chemotherapy, and then some additional cardiology. So that means that local people won't have to travel outside of West Hertfordshire. At the moment, a lot of the transfers is up into London, which can be a trouble in itself, or up to Luton and Dunstable for some specialists at work. Then obviously women's and children's services will remain at Watford because it's high risk and low risk maternity, the neonatal, inpatient surgery, and emergency specialist gynecology. So what do the staff think? So from the staff that I've spoken to, obviously the last 12 months has been a very tough month for us all. And we've been pushed to the limits in some of our buildings. We've had a lot of On a week, at some point on a daily basis, we were moving wards from one area to another ward because the wards were expanding, either COVID or non-COVID infections, non-infections, and it was really difficult having to move across buildings and move wards significantly. So if COVID has taught us anything, there's definitely lessons to learn for the future about from my personal point of view, rapidly expanding our critical care beds, and also having the importance of having a COVID-free site that we can continue with planned surgery and elective surgery well on a COVID-free site that protects those patients and the staff that aren't able to work on a COVID site. And I can't wait to see the new facilities and the better facilities being built up. And that's my quote. So what do we mean by intensive care? So by default, intensive care is intensive medicine. We look after all sorts of patients that have had major surgery, patients that come in following a cardiac arrest in the community, just very, very sick patients. And we offer what we call organ support, which would be offering them kidney support, liver support, neurology support if we need to. So we have our patients in levels. We have level ones, which is if they want intense monitoring, so we'll put them on a monitor and we'll bring them up and we'll just kind of look after them on a 1 nurse to 2 patients level. And then level 2 is putting them on dialysis or putting them on what we call non-invasive ventilation, where it's a very tight mask on their face and it assists them with their breathing. And then obviously level 3 is 2 or more, which for some people it's putting them on a ventilator, it's putting them on a dialysis machine, it's giving them extremely strong medication that we need to monitor them on a minute-by-minute basis. And each bed space obviously has quite a lot of equipment, beds, monitors. They have a one-to-one nurse, and we have a high level of doctors up here. And then the other thing that we do by intensive care or critical care, we do an outreach system where patients that are deteriorating on the ward, we will go out and look after those patients on the ward. We will offer advice from a critical care point of view and address their concerns and discuss with the doctors and put in plans to prevent them coming to ICU, because obviously coming to ICU is quite a significant impact on a patient. If we can prevent them coming, that's amazing. And if we can't, we can follow them through and help them. And then obviously once patients have left ITU, we will go back and see them on the ward and ensure that they're still having the care that we started in ICU. So the current challenges and future plans is we have an opportunity at this point is to think about design considerations that resolve current issues and help with future. So our biggest thing that we found during the pandemic, and I'm struggling with now in ICU, is that we don't have enough single side rooms. When it was first suggested to me that a brand new ICU would be 26 side rooms, I'm not going to hide from the fact that it terrified me. But now I've seen the rooms, and you'll see the pictures in the future, that actually it's a very positive way forward, I think. I've looked at a couple of intensive cares that do have side rooms, all side rooms, and we can manage it, and it's safe for patients, and it means that we can flex the beds, flex the patients. We can have COVID patients and non-COVID patients because they're all going to be protected in their side rooms. Obviously, we won't if we can't, but we can zone it, but it makes us a lot safer. And from a hospital point of view, it will allow us to have a lot more freedom with our beds. And then obviously we can have one-way routes for patients, so we're not crossing over people. That's what we've had to learn through COVID and through infections. And like I said, we'll be zoning. And then obviously in the new design, there's lots of natural light. There's a lot said in the research about patients in hospital. They need natural light, they need ventilation, they need sunshine, they need to be able to look out the window and watch the birds fly across the window. Being in hospitals are very depressing at the best of times, even for the staff. So being somewhere where there is natural light and you can see there's a world going on outside is a positive thing, and it helps people, boost them and lets them go out. And then obviously, amazingly, very excitingly, we're going to have improved digital systems, which will be our electric records. We won't have any paper to fill in, which will just be great. And this is what the new rooms are, an example of the new rooms that we're going to look like. As you can see, there's glass windows. So if you're sat at the nurse's station, you can see into all the rooms, but the rooms can be open or shut. And the dividing walls between, if there's 2 rooms next to each other, hopefully they'll be glass as well, so you can see through those. You've got the big light airy windows that you can see with the nested bathroom. Obviously these aren't ICU rooms. I think the one on the left with the yellow, as I'm looking at the left, hopefully it's your left, with the yellow, that's probably more likely an intensive care room. The right hand room is more like a ward room, but they're very big, bright and airy, which is lovely. And then the next picture is one with a attached bathroom, like a special facilities bathroom. And all the rooms will be set up to a certain spec, and it looks quite exciting. So further opportunities. We have the opportunity to think about the design of our supports and support a range of needs. I'm obviously going through this process with the architects at the moment for ICU, and it's very exciting. Think about the best things we can do. We compare ourselves, go look at other hospitals that have similar sizes ICU intensive care units, and we look at them and look at what we can have and what works for them and what doesn't work with them. So we have advantages that we can do this. We're minimising the need for patients between different parts of the hospital, which will be great to provide a better patient and care experience. At the moment, we do a bit of a flow through the hospital. It would be nice to try and keep people in their rooms as much as we can. We're increasing the number of signal rooms, which, as I've said, which also improves patients' dignity and privacy. Creating a nice, calming, healing environment that looks after people's physical health and promotes a good mental health and well-being. And there's lots of research out there that says that if we can make sure the environment is a calming and healing environment, then it goes a long way to helping patients get better. Lots of outdoor spaces, quiet spaces, the spiritual pastoral care facilities will be great. And then we're designing spaces that are welcoming and accessible to people of all ages and genders, and that cater for people's specific needs, such as physical learning disabilities, religion and belief, as well as language, dementia, mental health, maternity or pregnancy needs. And then the further opportunities for staff experience is for opportunity to ensure our amazing workforce have the facilities that support them in providing the best care, as well as enabling them to rest and recuperate. As I said, going back, we're going to have bigger size rooms. They're more consistent with wards and room layouts, so there's more space for people to work in. Everything will be there and then in the area that you need. So you've got your digitalization, which will be great. You've got your records. You're not running between different areas, finding store cupboards with machines in them and things. We're going to have more, if everything's where it is, we will be able to do more on the job training with suitably sized clinical areas and lots of meeting spaces within those areas that we can do training near our clinical areas. This is particularly exciting for ICU, intensive care, we're going to look for opportunities to develop new extended staff roles, particularly within clinical support such as therapy and pharmacy. And we're going to focus on staff wellbeing as a key guiding principle, addressing existing issues such as lack of changing facilities, restrooms, quiet space and sleeping provision. And this is also true for our team of volunteers who are really helping us and generous at this time with us across the hospital. And we're all really keen to start planning new ways of delivering care from modern surroundings with the latest technology. And that's key to all of this. If, when we're in a new environment and we like it, we're all more keen to make sure that we take on new challenges and find new ways of working, which I'm really excited that we're going to look forward to doing, to be able to help our patients get the care in the first class of facilities that they deserve.
Well, thank you very much, Vicky. For those of you who were trying to catch up, Vicky was not talking as fast as she normally does.
Sorry, I thought I was slow.
No, yeah, for you, Vicky, you were slow. So no, thank you. There will be time to tease out some further details. So I'm just going to do a few slides and then we can go back to Vicky if you've got any questions. So this is the engagement plan. So we launched our engagement on the 15th of February. I mean, we've been talking to our stakeholder reference group and groups in the community for as long as they would let us anyway. But this was a formal period of public engagement, which we started in mid-Feb, and we carry on until the 24th of March. We are talking to groups in the community. So as well as these 6 p.m. sessions, we have been talking to groups across West Herts. And although time is now running out a little bit, if you are a member of a local group in the community and you do want us to come and talk to you, please get in touch. There is an email address at the end of this presentation, and we'll be happy to give you a broad overview. It might be hard at this stage to find one of our clinical staff to come and talk to you, but we can certainly give broad overviews. And our feedback will go back, or your feedback rather, will be considered by our trust board, and they will use that when they are looking at the clinical brief and making decisions about where our services will be located. So importantly, as part of the engagement is your feedback in terms of the survey results. So if you haven't had a chance to do the survey, we would really like you to do that. The survey is being run by an independent organisation, and they will analyse the results. So what you tell us is what gets fed back to us. So it is an impartial process. And there are many ways to get involved. So please, if you have time, read the documents. There are summary versions, longer versions, as little or as much detail as you would like. The survey, which I've mentioned, the remaining sessions like this. So we have our Deputy Chief Nurse talking to us on Wednesday. Tomorrow we're talking about services from Hemel Hempstead. And we also have a session on diagnostics. We're hoping to also fit in an additional session on digital. So really we've covered a lot of ground, and all those recordings are going to be available on YouTube, so you can find them through our website. So please avail yourself of all the information that we've provided. And over to you for any questions via the chat function, please, to West Herts Communications. And I can see I've had a couple in already, so I will go for one which I think I can answer, and then I'll find one for Vicky, and I can see there are a few there. So there was a question about a new MRI at Hemel Hempstead, and that's a simple one, because yes, we definitely do plan to install a new MRI scanner at Hemel Hempstead. So I'm going to start with questions which pertain to critical care, because that is the nature of the session this evening. And so one of the questions on critical care was about patients at other sites, Vicky. So if we have patients at St Albans, which is going to be our site for planned surgical care and cancer care, or at Hemel Hempstead, which is an outpatient-based model. But if any patients at those sites suddenly need critical care, they become really unwell, can you describe how we would look after them?
Okay, so at St Albans, we already run an enhanced care service at St Albans. So during the day, there is ICU consultants running the theatre list, so they will support those patients during the day. And then at night time, we have what we call an ITU outreach service. So there's an ICU, very senior ICU nurse that sat over at St Albans on a night shift, covering any patients that deteriorate. There is some monitoring facilities over there, and the ability to us to support them and stabilize them, and then we would get a ambulance and transfer them straight over to us as soon as we're able. But there is staff there that's able to make them safe. Hemel, it's not likely that we are going to need critical care services over at Hemel if there's outpatient facilities there. If they are going to do any sort of procedures that does raise any risk that we think that they're going to need intensive care, they will be brought over to Watford before they do those services, those treatments on those staff patients, sorry. So then they can come straight to us. If we had to, we could do a retrieval service over to Hemel and pick the patients up.
Thank you. And can I ask, I have a question here about separation of children, and this is young children and older children. And this is a question that I'm going to ask about critical care for younger children and older children. Can you separate them, or indeed do you treat them here, or are critically unwell children treated elsewhere?
So Starfish would have 2 high dependency beds, because it's very unlikely that children need intensive care beds. If they do, they're very sick and they're very specialist, and they would need to be retrieved by what we call the CAT service, which is I can't think what it stands for, but it comes from Great Ormond Street. And there are specific retrieval service that come with an intensive care ambulance to pick up children. We will take children if we have to, but we're not paediatric trained. The doctors are paediatric trained, and they will look after children down in A&E. There's 2 HDU beds down in A&E as well, or intensive care beds in A&E. So if any child comes in that requires intensive care, they will look after them in A&E, and then we'll get what we call the retrieval team, Great Ormond Street, to come and get them. That's how we do it now. That's how it will go in the future. That's how Children's Services want it to run. So that's children from child from birth age, so that's babies that are 1, 2, 3 days that are term babies, up to the age of 16. After 16, they come up to us intensive care. Neonates, so babies under term age that are born, so premature babies. There is a NICU, so a neonatal intensive care unit here at Watford. The babies will stay here. Again, if they need specialist treatment, they will then get transferred up to Great Ormond Street, but they will get looked after here. And we have, I think we have 4 or 6 NICU, we call them NICU beds, neonatal intensive care beds here at Watford.
Thank you. And can you describe what the current scope is for relatives to see patients in critical care?
At the moment, so unfortunately at the moment we aren't allowed to allow visitors in unless they are end of life, and then we're letting them come in and visit the end of life patients. We are looking at, obviously in line with government guidance, to reopen our visiting, and we are looking at doing scheduled visiting. Unfortunately, we aren't allowed to open our visiting waiting rooms for relatives because of COVID and everything, but we are looking at planning and hopefully doing scheduled visiting. So people will be allowed to come in and out. We have 30, today we have 22 patients. So in order to get 22 visitors in today, we won't be able to. But what we will do is we have long-term patients. So we will say, right, they can come in on Monday, Wednesday, Friday, and then the new patients Tuesday, Thursday, Saturday. But I don't know, we are in the process of planning that and sorting that out now. We understand how difficult it is for relatives not to be able to come in.
Thank you. And can I ask you, maybe we could go back to the pictures of the rooms, because I just wanted to ask you, you talked about a nested bathroom. I wonder if you could explain what that is.
I think it's the picture before that, yeah, this one here. So I think what they mean by nested bathroom is it's a smaller bathroom, so it won't be for somebody who needs to go in with frames and stuff like that. It will just be a smaller, maybe a child's bathroom, or just a toilet and a sink, as opposed to being a shower facilities and things like that. But I'd have to probably clarify that with the architects.
Okay.
But that's my understanding.
Okay. And I think also there was something about it being like a Jack and Jill bathroom, that is so that 2 rooms can use the same bathroom, which is a design.
Yeah, a door either side.
Yes, yeah. So as we move on in our development and we have more and more designs to share with you, you will hear the phrase modern methods of construction. So the pictures that Vicky was sharing with you are designs that are tried and tested and trusted and used elsewhere. And so we have a limited scope in terms of our design, but they have been really thoroughly tested in terms of natural lights, really maximising the most light possible. So we will be using a lot of materials that come onto the site prefabricated, so already made, and that will reduce the construction time on the site and hopefully minimise some of the disruption. So I'm just going to look across and see if I have any questions that relate to critical care. I have something here about how is step down handled between COVID and non-COVID patients. So I don't know, Vicky, if you can talk a little bit about how you manage to step down your critical care patients.
So our critical care patients, so if they're COVID, at the moment they're going to the COVID wards. As the COVID wards are becoming less in the hospital, I expect them to be going to side rooms. But all our, whether they're COVID or non-COVID, all our step downs are followed up by our critical care outreach team. The COVID long-term patients that we're getting, they will be seen by outreach every day for at least the first week. But again, they're assessed daily. Our outreach consultants, or an intensive care consultant, reviews these patients daily as well to make sure that, you know, everything is going the way it should do. The non-COVID patients are going to be going to the non-COVID wards, and they will be in an open ward, which is a better environment for them. They can talk to people, they have a better chance to kind of catch up with what's going on in the world and what's happening. And again, they'll be seen by outreach as well.
Thank you. And while you were saying that, Vicky, I've had some confirmation on the design. So we're not planning Jack and Jill bathrooms. So nested bathrooms. It's to do with where the bathroom is in the room. rather than the size. But we're early days, so hopefully, Vicky, we can both be forgiven for not getting it exactly right. But
we can learn.
But keep following us, because this is going to be some years away, and so everything will resolve before it's built. We will know exactly what kind of bathrooms we're having. I wanted to ask you, Vicky, I've had a question in about outreach. So can you explain how outreach works in the hospital, and if it will work any differently with our new building?
So outreach is a trained critical care nurse. They're minimum a junior sister. We have a advanced nurse practitioner who has done her advanced skills course to run the service, and she does all the teaching on the service, ensures the skilled nurses that are going out to review the patients are skilled. They go out and they look at patients from a critical care point of view and assess them, whether in a more in-depth way and holistically of the patient's care. So they review the patients and they go discuss with the ICU consultant if there's anything that the ICU can support them from an organ support point of view. Patients are referred to outreach through the scoring system. When you get your observations done in hospital, there's a trigger system, and each observation scores a trigger. And if a trigger is above 3, you could potentially be referred to outreach, and outreach will come and review you. And then we will put in advice as to, from a critical care point of view, maybe you need a bit more fluid, for example. Or maybe you need to have a top up of an electrolyte. And it's just a supportive service to help with the doctors that are already caring for the patient. They're helping the nurses that are already caring for the patient. It's just an extra layer of safety and support for those patients, and to enable us to hopefully either prevent, because we are limited in our intensive care beds. We don't have an endless supply of intensive care beds. That's become very apparent in the last year. So it's to kind of support critical care without walls, so to do our service on the wards and prevent admissions into intensive care. And can it be, will it change? I envisage we'll get bigger. I think at the moment I have one outreach nurse on a shift. I suspect as the hospital population gets bigger, what we're finding is actually, because we're doing a lot of care in the community, patients when they come into hospital are coming in sicker. So therefore outreach service is in more demand. So as time goes on, I expect we will increase the people we have on outreach to go out and review patients.
Thank you. And thinking of your experience during COVID and how you've expanded into all sorts of areas that probably didn't expect to become critical care areas, how do you think it will be easier in the new building? So, I mean, obviously we don't want to think about another pandemic, but we have to. What is it about the design of the new building that makes you think that critical care can be expanded more easily and more rapidly?
So firstly, we're having more beds there, which is quite exciting. And secondly, what we're going to do is areas that we have looked at expanding now, we will make sure that they are set up to a specification. They won't have all our equipment in there, but they are bigger rooms, so therefore we can go in there quicker and we can use, and they're all side rooms, it's compartmentalized, so we can very quickly take over 4 side rooms in a ward nearby, so we can run that as an intensive care. Whereas what we found is we've really struggled with the sizes of the bed spaces. We've struggled with the size of piping of the oxygen flow going through. We've struggled with having the right, we need really big spaces for intensive care beds, and we haven't been able to find that on wards. So wards that they've been offered a 6-bedded bay, we've only been able to put like 3 patients in it. So if this ever happens again, and like you say, I really, really hope it doesn't, not in my lifetime anyway. I think I've had enough of a pandemic for my lifetime. But we will be able to expand very quickly, and that's one of the big discussions we're having in the redevelopment. If we as an intensive care, looking at what's happening in the pandemic, we need to be able to compartmentalize. We need to be able to take over half a ward very quickly, and it is literally in the blink of an eye. And if the rooms are set up to a certain specified standard, then we should be able to do that very easily.
Thank you. And thinking about facilities for families and carers, I know you have relatives rooms and you know, you do have some space, but have you talked about that with the architects, and what do you think would be provided for families and carers?
Yeah, so we've got what we're going to call a relatives hub. So we're going to have an overnight facilities for relatives. a couple of relatives rooms, if not 3, so we can, you know, sometimes families need some space and some time. We're going to have a quiet room for relatives so they're able to be spoken to by the doctors, or just need to be able to go and sit in a room and have 5 minutes because it's quite intense. And hopefully we'll have some kitchen facilities, which we don't have now, which will be really good, so they can make their own drinks and cups of tea, and bring in sandwiches and store it in a fridge, because unfortunately we don't have that facility now. So that'd be a really positive thing for relatives. And obviously we're going to look, obviously we'd have better restroom facilities, because again at the moment unfortunately that we only have one toilet for relatives, which is really difficult.
Thank you. Vicky, I've got a question about the summary care record, which may apply to critical care patients or any patients really. So can you say anything about how beneficial it might be to have access to the summary care record for patients when they are admitted?
Summary care is in having all patients' information there in front of us. Is that what the question is? Yeah.
Yeah.
Oh, it'd be amazing. It'd be amazing for us in ICU to, obviously for patients, particularly for patients that come in through A&E, they might come in at, if patients come in, they come in at 8, 9, 10, 11 o'clock at night, and we have no facility to be able to find the patient's past medical history. Obviously the families at these times are very, very distressed, so they will give us as much information as they're able to, but sometimes it could be really difficult because they're in that situation where they, you know, they can't think properly. If we have a summary of records, it would be great that we can have all that information for a patient. We can find out where they've been, what's happened to them, what tests they've had done. We can look on the system and see if they had a CT scan the previous week. We can see all that information there and then, and be able to make very quick clinical decisions and treatment plans.
Thank you. And have you had a bit of an insight into the electronic patient record?
Me, yes.
Yeah.
So I'm doing the lead for the EPR, electronic patient record for ICU, and I've seen it. It looks very exciting. We're probably one of the very few intensive cares in the country that are still using paper. So for an intensive care, it's very exciting for us to have electronic records, and it will really improve our nurse time to the patient and for the ward. It will be phenomenal. It'll make a massive difference to patient care on the wards, because we won't be caught up ticking pieces of paper. We can just do it on a screen in the bed space.
Thank you. I have a couple of questions which might not be directly for you, Vicky, so I'm going to see if I can give a little bit of an answer. So in terms of diagnostics, the question is, will everything be at Watford that will be required? And the answer is yes, and that is really why we are more closely defining what each hospital needs. So in terms of the emergency department, there will be a far bigger emphasis on assessment, and that means that there will be more diagnostic equipment at Watford, because what we want to do is assess what is wrong with patients before admitting them. So we don't see the need to admit patients and then begin all the investigations. We would rather get straight on with understanding what is wrong, carrying out as much assessment as possible, which is multi-specialty assessment. So that's pulling in staff from different areas to come and assess patients in A&E. And in the same way at St Albans and Hemel Hempstead, the diagnostic equipment would really meet the needs of the patients at that particular hospital. So for instance, the bone density scanner that I mentioned isn't appropriate for Watford or particularly St Albans, but it would be really useful at Hemel Hempstead, where we will be seeing patients with long-term conditions. So we don't, and so yes, the answer is we want everything to be right at Watford, but it's the same for St Albans and Hemel Hempstead. And the questioner then said that they assumed that the diagnostics will not be duplicated at St Albans. And I mean, diagnostic equipment is very expensive, so that's why it's important to understand what each site does and what each site needs. I wanted to answer a question here about funding for operations, and it's not really something that this organisation or Vicky could answer, but it's about questions with waiting for surgery, in this case ophthalmology. So that is something that falls to the commissioner in most cases it's Hearts Valley's clinical commissioning group. So unfortunately, that's not a question that we can answer, but I didn't want to ignore it either. But that is really a CCG question. There's something here about whether the electronic records will be run by a private company. And it's not correct to say they will be run by a private company, but it is a product that comes from a private company. And in our case, that company is Cerner. So there are different manufacturers, and the company we use is Cerner, but it will be very much run by the hospital staff. I can see that a question has come in. Oh, this is a really good one, Vicky, and I think you'll have a fair bit to say about this, because it's about mental illness and how people with mental health conditions are supported. So just to read it out correctly from the questioner, the question is, how are people with mental illness supported when they have a serious physical illness and they need critical care?
So we firstly we kind of speak to if they have a key worker. So usually they're brought in as an emergency, so that it's not something we can plan. If it's planned surgery, that's different. So I'll talk about that in a second. Let's talk about the emergencies. So as an emergency, they usually come in and they're very unwell. We have to treat the medical condition straight away, but obviously we have to be very aware that we have the mental wellness needs to be helped as well. So we will speak to their care worker. If they have a purple folder, we make sure we have the purple folder so we understand what's going on. If we need them to, if they're, say, for example, they have sensory issues and they need to be in a room on their own, we will accommodate them in a room in their own. ICU is a very, very noisy environment. There's always things going on. There's always alarms bleeping. There's always people rushing around. We try and keep the noise to a minimum, but obviously by the nature of our job, it's a noisy job. So we move patients inside rooms that have sensory concerns. We try and make sure they always have the same nurse so they can build up a bit of a relationship, get used to the nurse's voice. If they're asleep and ventilated on a breathing machine, we make sure they have the same nurse so they can become familiar with that nurse. If they have carers, we will make sure that the carers can come in and stay. And we have carers chairs that they can stay with them. Obviously, we're talking out of COVID times. COVID is very different. We will try and accommodate carers to stay, but it depends. Right in the middle of the pandemic in both ways, we couldn't have carers stay, unfortunately, because of the viral load in the air. But as our COVID numbers are coming down, we're able to accommodate this a lot more. We're able to put them in the rooms. We are also made sure that in our two special new side rooms that we've got there, special colours, which are very calming. And as I said, we keep the noise to a minimum. So that's kind of where we are with our emergencies. We help them as much as we can, but normally it's after the event when they've come in, because we can't do anything with the event when they come in because it's an emergency, but we do everything we can. We get our colleagues to come and help us, like our learning disabilities team. If they have a learning disability, we speak to the families, we find out what they like. For planned surgery, we will it's usually discussed in pre-admission clinic, but if they need to come in and they need to come to intensive care afterwards, we will walk them around the intensive care beforehand if that helps them. But again, that could be quite a frightening experience for them. We've found that in the past it's quite frightening, and then it puts the fear into them that they don't want to come even more because it is a noisy environment. So we try and take them into a room that's empty, that's quiet, so they can kind of just look around it and see how they can understand. And when we bring their carers in, so they can say, right, well, that's going to be a trigger. You can't have that in here. You can't have that in here. And we do that sort of stuff. We will bring in the clinical psychologist if we feel we need their help. If they need to have a one-to-one nurse with them, but there isn't a carer that's able to come, we will provide that support for them. But as I said, the nursing's one-to-one in ICU anyway. And the patients that need mental wellbeing support, we will make sure they're one-to-one as opposed to one-to-two. They won't be doubled up with another patient. So there's always a nurse around in that room to help them.
Thank you. And do you think the new layout will also be beneficial?
Yeah, absolutely. Side rooms with the glass doors, glass windows that we can turn, and it'd be better than not having curtains. I think they're going to be blinds in between the curtains, or that kind of glass that will move, hopefully. But it will be a lot quieter because everything will be contained. So you won't have, at the moment, we are a bay of 10 ICU patients in one bay. when alarms start going, it just escalates and it sounds very noisy. It's very noisy. If we've got doctors in there, if we have our other allied professionals in there doing physio, you know, having conversations with patients, it's all very noisy and loud. Whereas if we were in side rooms, it'll be a lot better environment. It'll be a lot quieter, a lot calmer. There'll just be 1 or 2 nurses in there at a time. So it'll just make it feel a lot safer for everybody.
Thank you. And can I ask you about staffing, Vicky? Because obviously it's quite a specialist, your workforce, and you've talked about there being more beds. So I'm sure a lot of our audience are thinking, well, if there's more beds, do we need more staff? So can you talk to us a little bit about recruitment, the pipeline, and if it's something that keeps you awake at night, or if you feel quite confident that you can get more staff?
So I do a lot of national calls with intensive cares, and actually as a country, as a intensive care unit, we're a lot better off with staffing than other areas. I don't know whether it's because we've done a massive recruitment drive overseas and we've got a lot of intensive care nurses. Interestingly, today, I've done some interviews today for our band 5 nurses. I've got 4 vacancies and 24 applied. And of the 24 applied, we wheedled down to 13, and we could have employed all 13 nurses. We haven't done because I don't have the vacancies, unfortunately. But we've employed 4 at least. We're also doing a program. So these nurses that wanted to come and work here, we're going to offer them to come and do what we call a external intensive care program. So we'll do them some key learning and key teaching and allow them to come and do some bank with us to build up their skills. So obviously over time, when we do expand, hopefully I will have a natural progression of workforce that will come to us and work with us. ICU is quite a glory place to work. Everybody wants to work intensive care, and especially after COVID, we seem to be getting a lot of people that want to come and work with us. So yes, I think there will be some struggles, but I don't think we'll be as bad as some other hospitals in other areas are.
Thank you, Vicky. That was really encouraging because, of course, during the peak of the pandemic, we had to train people up very quickly.
Yeah.
And so it sounds like the experience has actually, for some people, it's been good, and they've stayed with you or expressed a desire to come back to critical care. So that's been really, really positive.
Yeah, we've employed 6. We've employed 6 so far of the ones that came. So it's been a very positive thing. So it's good.
Excellent, excellent. I have a question about this is patient access. So patient access is a system that is used by the GPs. So this isn't a question for you, Vicky. You can breathe a bit here or have a glass of water. And the question is about whether the data can be shared. So the data that we collect on you and your patient electronic record, whether that will be shared with any commercial organisations. And as far as I know, that is absolutely not the intention. We treat patient data very sensitively and carefully, so we don't have any plans to share data with commercial organisations. I don't know from your experience, Vicky, if you've heard of us sharing data at all, or any plans to share data. I certainly haven't.
No, I haven't as yet. But that I mean, we share some data with GPs. We send information over to GPs and they send something to us, but there isn't a system that we have to do it. So at the moment we do it through emails.
Yeah, and we certainly don't have any arrangement with commercial organisations.
No, none at all.
So it's always patient initiated. So we would need the patients to agree, even if we share their information with other parts of the NHS. So it's quite a big rule for us on not sharing patient data. I've been asked the question about private beds. Will the hospital have private beds? And as far as I know, there are no plans for private beds. But is there ever any private critical care provided, Vicky? Do you know?
So we don't do private critical care, but we do take patients from private hospitals. So if someone became unwell at Bushy Spire, for example, that's our nearest private hospital, and they need critical care, then they will be transferred over to us. They do have some critical care facilities over there, but obviously they don't have intensive care facilities. So if they need to have serious ventilation or something, then they come over to us. Yeah.
Okay, thank you. Well, we're just with a few minutes to go, and there are no other questions that have come in for Vicky. So if we could just sort of flick to the slide at the end, so you've got all the details in front of you about how to get involved. And what I'd like to do before we finish off is please remind you that whilst we do have a little bit of time to come out to your group, if you're a member of a group or a society, please get in touch and we will really try to make that happen. Do please have a look at doing the survey. It won't take that long. There is a lot of demographic information that we ask of you at the end, but that's really important to us because we want to be sure that the information that we have, the feedback we have, is representative of the communities that we serve. And do have a look at some of the information that we have provided for you. So I'd like to thank Vicky very much for her time. She is exceptionally busy, so we're very lucky to have had her company tonight and also lucky to have had your company. Please come back and join one of our remaining sessions at 6 o'clock and look at some of the sessions that we've already had. And above all, look after yourselves. Good evening.